I'm Peter Block at AHA at the annual meeting 2019 for On the Scene, and it is the end of day one, and we're doing a general wrap-up, and then we're going to do an individual ischemia wrap-up, the big blockbuster trial that's being presented. And so the question now is, we have two important studies, I think, interesting studies. Heart failure in the elderly patients treated with dapagliflozin, and we have colchicine, of all things, now once again bumping up to the surface. On my left, Deepak Bhatt. Forgot to introduce you, Deepak, from the Brigham and Women's. Deepak's an old friend. We do these wrap-ups together. So let's get to the chase.
Yeah,
let's go to the heart failure in the elderly compared to the not-so-elderly with dapagliflozin. Good heart failure drug, also good diabetic drug.
Right, absolutely.
Interesting trial.
There's a lot being presented from DAPA heart failure. Today was the diabetes, no diabetes. Tomorrow, the elderly. But in terms
of I'm sorry, that's right. Today is the diabetics.
But there's actually a lot of stuff being presented from the trial, and I think a lot more to come in the future. But basically, in terms of the message, the drug, dapagliflozin, works in heart failure patients with reduced ejection fraction with diabetes, as many were hoping and anticipating, but also, importantly, seems to work just as well in those without diabetes.
Well, we were chatting about this just a moment ago, and I said, well, this isn't a diabetic drug for people, without diabetes, what's going on? It's a heart failure drug.
Yeah, so it's probably confusing to doctors out there. It's definitely a good diabetes drug. It works well in people in the secondary prevention, even primary prevention type diabetes. We showed that in DECLARE with dapagliflozin. But what has been advanced now is studying the drug as a heart failure drug. And we already knew from other trials, subgroup analyses, post hoc analyses, that it reduced heart failure in people with diabetes. But what DAPA heart failure has shown is that even without diabetes, it's still reducing heart failure and even death in those people who already have heart failure with reduced ejection fraction. That's amazing, and says that the drug is doing something else beyond what we know it does.
Yeah, and maybe it's doing a little combination of both. And people that are sort of almost diabetic, maybe they confound I don't know, but it's an interesting drug, and it certainly does a great job with heart failure. And it is, I think, going forward, going to be a drug that we use more and more in cardiology rather than just diabetes.
Absolutely. I think it just points again, as a series of trials have, that as cardiologists, we really need to be on top of what's going on in diabetology. And certainly drugs like SGLT2 inhibitors have to be in our comfort zone, especially for folks focused on cardiovascular prevention.
Right.
But now even the heart failure docs, right? So it's really something that general cardiologists need to know.
There you go. I think that's critical. We need to look around a little bit more.
Yeah.
So that's number one. And then there's colchicine. I mean, for God's sakes, here we are suddenly bubbling up a drug that we've had around for 190 years, right? Not exactly, but nonetheless.
Yeah, colchicine's making a comeback.
Yes. So tell me about this colchicine trial.
Sure. So we already know colchicine's good for certain situations with pericarditis, for example, but data to support that. But what this study looked at was patients with myocardial infarction and to see whether colchicine would provide some additional benefit beyond standard therapies. And it turned out as a positive trial of significant reduction in major adverse cardiovascular events and a substantial reduction. So it points to the fact, as the CANTOS trial that Dr. Ritgerd published some while ago with canakinumab, but it points to the fact now a second trial showing that an anti-inflammatory drug reduces major adverse cardiovascular events. That's pretty important.
Yeah, it's anti-inflammatory in a funny way, though, right? It interferes with mitosis, as I remember back from my medical school days.
Yeah, no, that's really good. And it points to the fact that we're not really sure what all pathways of inflammation might be important. CANTOS was positive with canakinumab, but when methotrexate was examined, that wasn't positive. Right. So it's not that any anti-inflammatory is going to reduce cardiovascular events. Probably some of them increase cardiovascular events. So it really depends on the mechanism of action. Colchicine, is a bit more of a general action. Canakinumab is very specific as a monoclonal antibody. But still, this opens up the field even further. I think there's going to be a lot of companies looking at anti-inflammatories in cardiovascular medicine.
I would agree. So should we use colchicine more and more? The outcomes here are impressive.
Yeah, I think it's a good question. It'll depend, I believe, on physicians' comfort level with using colchicine so broadly. There was, as expected, more diarrhea and GI side effects. with colchicine. As well, you know, the overall MACE was significantly reduced, but as far as some of the individual endpoints, they all were going in the right direction, but not significantly reduced. So, you know, I think here we want to just wait and see a little bit further, but on first glance, the data look quite strong.
I will bet you that in the next 10 years, we all in medicine look more and more at these, you know, remember yellow bile and green bile and black bile from
Right.
the Middle Ages?
Yes.
We're back there, right? All
Yeah.
these bad these inflammatory molecules that are running around when we get into trouble are not good for you.
Absolutely. I mean, you know, Peter Libby's been telling us for years that inflammation plays a central role in atherosclerosis and atherothrombosis, and now the clinical trial data are supporting it.
So there you have it. The wrap up in general for day one. Ischemia will be separate.